चलो चलो रीस्टार्ट। तूफान सर आए नहीं अभी?
आ
सर
गए
हम है
सर, आ
ना।
गए सर, कब से आए?
ओके सर, वेलकम। स्टार्ट करते हैं फिर। द फुल पैनल इज देयर नाउ, वी कैन स्टार्ट। श्रेया, रिकॉर्डिंग।
Sir, I'm not able to share the PPT. Please, anyone can share.
शुभ शेयर कर रहा हूँ।
यस सर।
सॉरी। Okay, we are all set now. This is the 252nd edition of Thursday Musings. So we'll be talking about dyskinesias, seeing some videos on it from our uh, previous speaker will be repeating, who will be continuing the series. Uh, the session is being recorded. The recording will be on the YouTube for later on viewing. The questions are invited in the chat box, so you can type the questions and send it to in the chat box. Next slide. Handing over the session to the chairman of this program, Professor Dr. Pati sir. Over to you, sir.
Thank you. Good evening, everybody. Thank you, Dr. Ali. And I welcome all to this webinar, Thursday Musings. Next slide, please. I have the pleasure to invite and acknowledge the presence of our vibrant moderators, Dr. Amrit Patajoshi, Dr. Alim Siddiqui, Dr. Shobit Gar, and Dr. Vishal Chavra. Welcome, everybody. Dr. Anurag Das, our chairperson today, is currently consultant and director of Psychiatric Clinic and Health City Super Specialty Hospital, Guwahati, Assam. Runs a trust and NGO, Monir Moy, and spreading awareness regarding mental health issues. Clinical experience over 10 years, publications, around 21 papers published in national and international journals. Has 9 chapters published in various textbooks of psychiatry. Is a co-author of 2 books in psychiatry, community psychiatry, IPS publication, and psychopharmacology, Springer's publication. Special interest, child and adolescent psychiatry and community psychiatry. Welcome, Dr. Anurag. Dr. Cyril John Sentilanathan. Dr. Cyril John Sentilanathan is a psychiatrist born and raised in Mumbai. She practices at LH Hiranandani Hospital, Powai, and Holy Spirit Hospital, Andheri, and has been in private practice for the last 18 years. She completed her MD Psychiatry at Lokmanya Tilak Municipal Medical College. She is presently the co-chairperson of the NDP Task Force and Committee of the Indian Psychiatric Society. She has held various posts in Indian Psychiatric Society and Bombay Psychiatric Society. She was assistant honorary psychiatrist at Radhavadi Hospital, Kathakar, and she then invited speaker at various national and international psychiatric conferences. Mental health awareness and destigmatizing mental illness has driven Dr. Cyril to deliver lectures across the length and breadth of the country. As a passionate advocate of mental health, she has conducted a myriad of programs through various social media platforms as well as podcasts. Welcome, Dr. Cyril. Now over to the chairperson of this meeting. Someone will introduce our speaker. Who will be introducing the speaker? Dr. Bhaumik is the speaker who will introduce.
Dr.
Dr. Anurag will introduce, and both of you then introduce the topic. Over to Anurag, please.
Yeah, thank you, Tufan sir. At the very outset, my sincere gratitude and thanks to the team of Thursday Musings for including me in today's CME. And I welcome Dr. Shubhrajesh Subhash Bhaumik, who will be speaking on a very important topic of dyskinesia. It's very important as clinicians, as psychiatrists, we do get a lot of cases, and we tend to either misdiagnose it or overlook it because many a times we do overlook the neurological part of the patients when they present with us. So it's very important to differentiate between the functional part and the organic part. And I think with the videos present today, I think it will be definitely helpful for our audience participants. And I guess it will be very helpful for us as clinicians. And I hope it's a very insightful lecture that is coming up. So just to introduce our speaker today, Dr. Subhadesh Subhash Bhomik is an MD Medicine and DM Neurology. His areas of interest are neurogenetics, neuroimmunology, and he has 20 important publications in indexed national and international journals. He has a few awards and recognitions to go with him. He is a expert panelist in various forums, and I welcome Dr. Shubhrojit to the Thursday Musings, which has been very successfully running over the past few years. Now I hand over the proceedings to Dr. Cheryl, madam, who will be giving a brief introduction on the topic, and also go ahead with the proceedings, and then Dr. Shovik sir can take over the lecture. Thank you, sir. Over to Dr. Cheryl, ma'am.
Yeah, good evening, everyone. It's really nice to be part of the Thursday Musings with Live CME. So, gratitude to the team for having me as a chairperson, and really looking forward to such an important topic. We're talking about dyskinesias, and I think the interlocking between psychiatry and neurology, and I think we have a great speaker with expertise in movement disorders to throw light on it. In day-to-day psychiatric practice, we kind of struggle sometimes with tardive dyskinesia. I think a little lesser now with newer second generation antipsychotic medications, but we see patients, taking the older typical antipsychotic medications for last 40, 50 years, and then they're coming with orolingual movements or tardive dyskinesia. Our patients with akathisia. Sometimes we see patients with chorea who present to us first, and then we kind of look at the dyskinesic disorders that are there. So I think the video presentation where we'll be able to see live cases, decipher the differences between the differential diagnosis and dyskinesias will be really eye-opening for all of us attending here. So looking forward to a very fruitful session. Handing it over to the speaker.
Yeah, Dr. Bhomik, sir, you can start with your presentation.
Thank you, Dr. Das and Dr. Cheryl, for your kind introduction. And here we are again in this very nice online series. Sharing my presentation. I think you can see my presentation, right?
Yes, sir, you can go full screen.
Okay, so we'll be talking about dyskinesias tonight. So this is a presentation of selected patients that I have seen over the time, or my teachers have shown me. And for this is very important, as Dr. Cheryl mentioned, because sometimes neurological disorders and psychiatric disorders can have overlaps. So movement disorders as such are classified into hypokinetic disorders and hyperkinetic disorders. Hypokinetic disorders means there is paucity of voluntary and automatic movements, and hyperkinetic disorders are abnormal involuntary excess of body movements. And there are some other disorders which are often seen by movement disorder specialists in conjunction to movement disorders, like ataxic disorders, disorders with prominent spasticity, and some stiffness syndromes. So there are a lot of hyperkinetic disorders, and the nomenclature is vast. But dyskinesia is just a general term for abnormal involuntary movements. It can include any type of abnormal involuntary movement, but when we talk about dyskinesia, we generally refer to the disorders with chorea, or a combination of chorea, dystonia, and sometimes stereotypy. Disorders like tremor, myoclonus, etc., tics, are not classically included in the term dyskinesia in general use. So drug-induced dyskinesia is the most common type of dyskinesia that we come across in our routine clinical practice. And as a movement disorder specialist, I commonly see levodopa-induced dyskinesia. So Parkinson's disease is a common neurodegenerative disorder affecting middle-aged to elderly people. And when they have been on levodopa for a number of years, they tend to develop some involuntary, non-rhythmic choric or choreodystonic or sometimes stereotypic movements of different body parts. So this is known as levodopa-induced dyskinesia. For example, this patient, you can see that the upper body is constantly doing some dancing-like movements. There are also some orolingual movements. And this is a typical example of a peak dose dyskinesia that a patient of Parkinson's disease develops after taking levodopa. Roughly about 50% of patients of Parkinson's disease who are on levodopa for about 5 years will develop such dyskinesia. This is another example. This is a patient of Parkinson's disease who is in the off state, means he has been off levodopa for some hours. And you can see that he is very slow. Okay. Left side examination would show marked rigidity. And you may also find some tremulousness of hands and legs. But in the on state, he will develop. So this patient does have some upper body movements, especially the right-sided upper limb movement is dyskinetic. But he has more abnormalities in the lower limbs. So lower limb is predominantly affected. Compared to previous patient, this patient has dyskinesia more in the lower limbs. So depending upon the type of dyskinesia, it can be a peak dose dyskinesia, it can be a square wave dyskinesia, or it can be a biphasic dyskinesia. Peak dose dyskinesia means when the drug levels are at its peak, the patient develops dyskinesia. Square wave dyskinesia is such a state that whenever the patient goes into the on state, he will come with dyskinesia. Otherwise, he will directly shift to off state. So he will not have a good on. The on will be always with some dyskinesia. Typically, this peak dose dyskinesia and square dose dyskinesia affects the upper body parts. And in elderly people, it tends to affect the orolingual region. In patients with markedly asymmetric Parkinson's disease, the dyskinesia tends to affect the more severe side. Whereas biphasic dyskinesia tends to affect the lower limbs more. Biphasic dyskinesia comes and goes, like with the uprising of levodopa levels in the blood, or with the when the levodopa levels are wearing off, then the patient develops some dyskinetic movements of the limbs. They are characteristically in the lower limbs, but sometimes some exceptions do occur. So what are the risk factors of a patient of Parkinson's disease developing levodopa-induced dyskinesia? So if a patient has young age of symptoms at onset, patient is having a low body weight, especially females, and with severe motor disability, they are more likely to get levodopa-induced dyskinesia. So we should be very careful with the dose that we are giving them. And sometimes or I should say many times we see that patients are on anticholinergic medications like benzoxazole or trihexyphenidyl. These are the patients who are more likely to develop dyskinesias. So not only levodopa, in other patients, some drugs can induce certain types of dyskinesia. For example, some antidepressants, anti-epileptic medications, antihistaminic medications, anticholinergic drugs, and psychostimulants can induce dyskinesia. So this video shows prominent orofacial dyskinesia induced by phenytoin. The patient came in status epilepticus and patient improved with phenytoin, but she developed these abnormal movements of the face, excessive blinking and this choric movements of the face. This is phenytoin-induced dyskinesia. So for a psychiatrist, this is very important because they commonly, psychiatrists commonly use dopamine receptor blocking drugs. So there are several types of movement disorders that can happen to a patient who is on such drugs. This can be in the form of acute dystonia, rabbit syndrome, frank drug-induced Parkinsonism, and idiosyncratic neuroleptic malignant syndrome, withdrawal emergent syndrome, tardive dyskinesia, and some other tardive syndromes. So not necessarily the antipsychotic drugs, the drugs which are used for other purposes can also have dopamine receptor blocking property and can induce such movement disorders. So these include prochlorperazine, which is very commonly used for patients who have vertigo, and then the levosulpiride patient who have a lot of gastritis or gastroesophageal reflux disease, and then certain antiemetic medications like metoclopramide. So this patient who developed vertigo, acute vertigo, was given Stemetil, and the patient developed acute dystonia. So acute dystonia can be in the form of oculogyric crisis or a prominent cervical dystonia, and the treatment is with anticholinergic drugs. And after stopping the medication and with the use of anticholinergic drugs, can be resolution of symptoms within days to weeks. So this is rabbit syndrome. So vertical movements of the lip without involvement of the tongue. This develops in a patient who are on first generation antipsychotic agents for some time. And this is a localized form of Parkinsonism, and it responds to anticholinergic medication. Now, I have not enumerated each of these movement disorders in the presentation, but we can roughly discuss here. So patients who are on dopamine receptor blocking drugs can develop Parkinsonism. Sometimes this Parkinsonism is reversible on omission of such medications, and it may take few months, like 3 months to 6 months. And without dopaminergic agents, if the patient is back to baseline, then we call it truly drug-induced Parkinsonism. But some patients who have underlying neurodegeneration, for example, Parkinson's disease or other related disorders, can develop, and these dopamine receptor blockers triggers the onset of motor symptoms in those patients. And despite omission of such medications, the patient has Parkinsonism, which is progressive for the rest of the life. And this is known as, this is not a truly drug-induced Parkinsonism, but the Parkinsonism is triggered by these agents, and the patient has an underlying neurodegenerative disorder. And this has been proven by some DAT scans and biopsy-proven cases also. So there are some cases of truly drug-induced Parkinsonism, and there are other cases where an underlying neurodegeneration is there, and the drugs just trigger the Parkinsonism. Then neuroleptic malignant syndrome is an idiosyncratic reaction to antipsychotic agents, and the patient develops severe rigidity, akinesia, and dysautonomia, along with hyperpyrexia. And the patients the syndrome can be very severe and life-threatening. Withdrawal emergent syndrome is a reversible syndrome in patients who are on dopamine receptor blockers. This is usually seen in children or younger individuals, where within a month of omission of such agent, the dyskinesia disappears. So it's a form of dyskinesia, but it's reversible. Tardive dyskinesia, on the other hand, so tardive dyskinesia develops in people who are on dopamine receptor blocking drugs after a delay of few months, but the duration can be as short as 2 weeks in elderly people, and they tend to persist. And the important feature about tardive dyskinesia is that it tends to persist for a longer time. In many, this will persist lifelong. And if you try to omit the drugs completely, tardive dyskinesia will worsen. And upon reintroduction of the medication, which is required in many patients who are having a lot of psychiatric issues, then the tardive dyskinesia will be the severity will be less. So classic tardive dyskinesia involves the orofacial region. So the movements can be choric, which means non-rhythmic, unpredictable. But many times these movements are stereotypic or patterned. The same type of orolingual movement continuing again and again. And this may be associated with some choreiform movements of the limbs, like in this patient, subtle chorea of the lower limbs. There are other tardive syndromes. So this tardive dyskinesia, sometimes it is very difficult to differentiate from spontaneous orofacial dyskinesia. So even before the antipsychotic agents were introduced for commercial use, the patient who had disorders like schizophrenia had some abnormal facial and limb movements, and this has been documented in literature. So they do have some abnormal movements related to their basic psychiatric disorder. And then there are many elderly people who have not been exposed to this classical dopamine receptor blocking drugs, but who have been on some other drugs like antidepressants, anti-anxiety medications. They also develop some orofacial dyskinesia. It's very difficult to tell whether it is tardive dyskinesia, because these forms of abnormal movements can develop spontaneously, especially in elderly people who are edentulous. So you check the records, you don't find any dopamine receptor blocking drug, but still the patient has features very similar to tardive dyskinesia and tends to persist. How to manage this tardive dyskinesia? So this is from my own experience and some points from the literature. So in India, we have only one VMAT2 inhibitors, that is vesicular monoamine transporter inhibitor, tetrabenazine. It depletes the dopamine levels. So tardive dyskinesia is thought to be because of D2 receptor hypersensitivity, but this simple hypothesis doesn't explain everything that we know about tardive dyskinesia. But it's known that blocking the dopamine receptors or depleting the dopamine reduces the tardive dyskinesia. So tetrabenazine is a very effective medication for tardive dyskinesia. But the problems or challenges I face with tetrabenazine is that many of these patients will have concomitant Parkinsonism or akathisia. And in these patients, tetrabenazine can worsen the Parkinsonism or akathisia. So tetrabenazine, the major side effects are sedation, aggravation of Parkinsonism, restlessness or akathisia, and depression. So using this medication judiciously is very important. Sometimes if you just introduce this medication and increase the dose of tetrabenazine, the patient in the next visit will come in a very bad Parkinsonian state. So in a patient who has a lot of rigidity, slowness, I find addition of amantadine very useful. So amantadine is a medication which is used in people with Parkinson's disease who develop levodopa-induced dyskinesia. These patients are managed by either reducing the dose of levodopa and or addition of amantadine. So amantadine is a NMDA receptor antagonist, and it has antidyskinetic property. And in patients who have a combination of tardive syndrome, I find that this is a good agent which can reduce the dyskinesia a bit and also not worsen Parkinsonism. A very important thing to note is that many of these patients are on anticholinergic medications. And we know that anticholinergic drugs worsen tardive dyskinesia. It is also seen in people with Parkinson's disease, but tardive dyskinesia, if there is no clear-cut dystonia, anticholinergic drugs are not to be used. And if you change this anticholinergic medication to amantadine, which may have some anticholinergic property, but also has antidyskinetic property, this often helps. And then, of course, we also use GABAergic medications like clonazepam, and nowadays zolpidem is often used to reduce the severity of tardive dyskinesia. Sometimes, or many a times, I would say, in patients who are having lot of psychosis or bad psychiatric disease, the reintroduction of lower potency or lower dose of antipsychotic is very important. So you replace some first generation antipsychotics with second generation antipsychotics, and you may be able to lessen the severity of tardive dyskinesia. For example, clozapine use clozapine also has some antidyskinetic property. Clozapine therapy can help in tardive dyskinesia. In some patients, tardive dyskinesia is not the main problem. Although dystonia and dyskinesia can coexist together, dystonia is a predominant problem in younger patients. So younger patients on this first generation and some second generation antipsychotic drugs and some drugs which have dopamine receptor blocking drug property develop dystonia. So this dystonia is characterized by retrocolis. So you can see that the relative is holding the head from going back, and there is a arching of the back, and sometimes it can be associated with some lightning fast movements of the upper trunk and the upper limbs. So these are either known as dystonic spasms or myoclonus. So this is characteristically responsive to anticholinergic medications, and sometimes it can be very challenging. Sometimes you have to use all the agents like VMAT2 inhibitors, anticholinergic drugs, amantadine, as well as some low potency antipsychotic medications. And when it is refractory and the quality of life is very poor, then if the symptom is just localized to the neck, you can use the botulinum toxin injections, or if there is generalized dystonia, then surgical management like deep brain stimulation is often helpful. So there are some other tardive syndromes which develop in patients who are on dopamine receptor blocking drugs, which include tardive myoclonus, tardive tremor, tics, chorea, akathisia, and pain are a bit of sensory syndromes in which akathisia means inner restlessness, and pain. Sometimes these patients often come with complaint of a lot of oral pain, genital pain, and this is very difficult to manage with medications. And then there are some unusual movements which we come across, not as part of dopamine receptor blocking agents, but developing spontaneously or after some surgical procedure or some trigger. So these are abdominal dyskinesias. You can find some videos in the literature. And then I saw this patient. This is a very unusual patient who underwent hemimandibulectomy for oral cancer and then developed the spasms of the pectoralis.
Okay, બંને આંખે ટાઈટલી બંધ કરો, બંને આંખે જોરથી બંધ કરો.
So you can see the intermittent movements of this pectoralis myocutaneous flap. And similar kind of movements are also seen in some patients with shoulder dyskinesia or abdominal dyskinesia. We don't know the exact pathophysiology, and these are usually challenging to treat. This patient responded nicely to botulinum toxin injections. So dyskinesia, as I mentioned, when we are referring to dyskinesia, we generally talk about chorea, choreodystonia, or stereotypy. And the distribution of these abnormal movements can often provide a guide to the etiology. For example, if a patient comes with choreic movements, and if you see that the upper face is also involved in addition to lower face and body, then you are likely to think about Huntington disease. And these patients can also come with a lot of behavioral abnormalities, and psychiatric issues. So it's a diagnosis not to be missed because of the prognosis that it carries and because of the transmission, hazards of transmission to the next generation. Then dyskinesias which affect particularly the orolingual region or orobuccofacial region, these can be like tardive dyskinesia, then some acquired disorders like acquired hepatocerebral degeneration, choreoacanthocytosis. Often the clue is feeding dystonia. As soon as the patient puts some food into the mouth, it is the tongue protrudes out and pushes the food outside the mouth. Similar symptoms can also be seen in patients with genetic disorder known as Lesch-Nyhan syndrome. These patients also have prominent mutilating behavior. They are very aggressive towards others. They often end up biting others or harming themselves. Then the neurodegeneration with brain iron accumulation, the characteristic disorder is pantothenate kinase associated neurodegeneration, which can also involve the orolingual region prominently, and Lubach disease, another genetic neurodegeneration. When you have unilateral dyskinesia, or hemichorea, or hemichorea dystonia, or hemibalism, then you should think about structural lesions, but some metabolic causes like hyperglycemia can also cause such unilateral involvement. So as you can see in this patient, this is a patient of Huntington disease. You can see that intermittent eyebrow elevation and forehead activation in this patient is a patient of Huntington's disease. And tardive dyskinesia, on the other hand, characteristically involves the lower face and the upper face is spared. So these will be just the next few slides will be just repetition of videos that I probably showed you before, because these can come into differential diagnosis of dyskinesia. So chorea is just a rapid, abrupt, non-pattern movement, non-rhythmic movement, and it's not sustained. There is a fluid characteristic to the overall movements, and these movements are purposeless, and there can be motor impersistence. So, classic case of Huntington's disease, it's an autosomal dominant neurodegenerative disorder caused by trinucleotide repeat expansion in the Huntington gene. Sometimes these dyskinetic movements or chorea can be very subtle. It appears as fidgetiness, nervousness, and clumsiness of hands. So in an elderly patient with such familial or autosomal dominant chorea, the most likely diagnosis is Huntington disease, but some patients have phenocopies, like they are not Huntington disease, but they are other genetic disorders which have symptoms similar to Huntington disease. So these can be like DRPLA, HDL, or Huntington-like disease 1, 2, 3, and some spinocerebellar ataxias. And macloid disease is an X-linked disorder.
Now, can you count backwards from 100 by sevens?
100.
So this is a type of neuroacanthocytosis syndrome where if you order a peripheral smear, then you may see acanthocytes. Neuroacanthocytosis or choreoacanthocytosis is autosomal recessive, and macloid disease in which patients have a very striking blood group is X-linked. And because of the random X inactivation, you may see some subtle features in the mother. So sometimes chorea can be a manifestations of moya disease. It's a vascular disorder of the brain where there is prominent obstruction to the or thinning of the internal carotid arteries, which leads to formation of several collaterals, giving a puff of smoke appearance in neuroradiology. Then chorea can be immune mediated. For example, this patient has systemic lupus erythematosus, and these patients commonly have antiphospholipid antibodies, which can damage the basal ganglia through immune mediated mechanisms or vascular mechanisms and induce such chorea. And these patients require both immunotherapy as well as anticoagulation. Another immune mediated cause to be kept in mind in children with acute to subacute onset of chorea. Sometimes the chorea can be unilateral, and sometimes the chorea can be very severe. The patient may present in status. So other features, systemic features, often give clues to diagnosis, but these may be absent. And sometimes patients who are having synonym chorea, especially the females, they have remission, but during pregnancy again, this chorea appears. It's known as chorea gravidarum. As I mentioned, unilateral chorea balism can often be due to metabolic causes like hyperglycemic, hyperosmolar state. The clue is given by the characteristic neuroimaging and finding of high RBS. Acute hemibalism, do not forget stroke. The stroke can involve the subthalamic nucleus, but lesion in some other brain areas can also cause hemibalism. Other causes are deep hypothermia, like patients who undergo cardiac bypass under deep hypothermia often develop bilateral chorea. Patients who have hypoxic injury can develop chorea. And this will be my last slide. I'm sorry I was fast today and I didn't get much opportunity to make slides. You can see all forms of dyskinesia here. And the movement disorder specialist dance post-conference. I think I will stop my presentation here and we can leave more time for discussion. And this discussion is something that is very that has carries a lot of teaching potential, and I also learn from this discussion.
Thank you, sir. Very nice videos, if I may say. Over to chairpersons for their opening remarks. Questions are invited in the chat box.
Yeah, thank you, Bomik sir, for such a comprehensive and descriptive type of a lecture. And the videos really help to differentiate between the various movement disorders. And it's very difficult as part of psychiatrist for us sometimes when the patients present to us, and it's very difficult to make it out whether it is a functional movement disorder or some organicity is present. So it was very insightful for me. As a clinician, and I am very definite that all the participants have gained something from your videos, specially. And over to Cheryl ma'am for her comments, and then we can take the questions which are there in the chat box. I request all the participants who have any doubts or any queries to clarify, they can put the questions in the chat box so that we can read it out, and Dr. Bhomik can answer one by one. Over to Cheryl ma'am. Any comments or remarks?
Yeah, thank you so much. Thank you so much, Dr. Bomik. It was such an insightful, you know, topic and talk that you gave. Sometimes, we are a little, as clinicians, when we are a little in a dilemma about the different types, and you're reading up, when
ଯିବା
actually
ଆଙ୍କ
you're
ଘରକୁ
observing
ଗୌରୀ
and
ଆସୁଛି ଟିକେ ଯିବା
watching the videos of the different dyskinesias, it made it so easy and lucid to differentiate, and we really thank you for that. I'm sure that we have a lot of queries. I think even before the session started, there were a lot of people who were putting in their queries. So I won't take time from that and hand it over to the moderators to take the questions further.
I think Sorak, a wonderful presentation. Please,
Thank
can you actually prime us? You touched it. How to actually say that dyskinesia is, if we can differentiate, it's an levodopa induced dyskinesia versus our antipsychotic or psychotropics induced dyskinesia. Can we differentiate?
So levodopa-induced dyskinesia will be basically it comes and goes. Number one, and patient has to be on levodopa.
so
Patient is on levodopa, right? So patients of Parkinson. So levodopa induces dyskinesia in patients who have neurodegeneration. So pulsatile use of levodopa in patients who have uh, nigrostriatal degeneration, and patients who have, like, sometimes it's an indication that the postsynaptic receptors or postsynaptic neurons are preserved, and because of these facts, the prognosis seems to be good. Like in patients who have atypical Parkinsonism or Parkinson plus syndromes like PSP, MSA, in these patients don't have much. They may develop some orolingual dyskinesia or dystonia, but they are rare because the postsynaptic neurons are degenerated and therefore they are not prone to dyskinesia. In Parkinson's disease, because the postsynaptic neurons are there, the receptors develop some hypersensitivity, plus there is some changes in the pathophysiology as well as in the metabolism of the medications. This leads to levodopa-induced dyskinesia. So again, it's not always there. So in patients who just start to develop dyskinesia, it develops as a peak dose dyskinesia, or patients who are on a very low dose of levodopa, it can develop during the on phase or during the off phase, which is known as biphasic dyskinesia. And they will switch between the off phase, on phase, then dyskinetic phase, then again a good on, then off phase. Later on, as the disease progresses, they will develop a square wave dyskinesia. Means either they are off, or they develop or they have improved mobility, but with dyskinesia all the time. So uh, so why is there question, do you want to know that some patients of Parkinson's disease are on antipsychotic medications and
yes,
they
yes,
develop dyskinesia? That's
Yeah,
what.
yes, yes,
and
yes, yes.
and more so, like when we say talk about tardive dyskinesia, we say that amplitude is lesser than routine coriform ethitoid movements, and they are more peripherally centered. if they develop early onset. So can we see from the amplitude, the nature of the movements, can we differentiate? That was the question.
No,
Specifically,
it's variable for from like person to person. Some patients will have very mild dyskinesia and they are not aware of the dyskinesias. So many patients, like in tardive dyskinesia, same in Parkinson's disease patients, many times they are not aware of the dyskinesias, and they are noticed by the relatives first, and they are brought to attention to the neurologist. So these patients, we classify the dyskinesia as non-bothersome dyskinesia or mild dyskinesia. So they are not worried about dyskinesia. It can be very mild, and when the severity increases, then only it becomes bothersome. So there can be variety. I don't think based on the phenomenology itself, we can differentiate between the levodopa-induced dyskinesia and the tardive dyskinesia.
and I think an excellent clinical pointer which you gave us is forehead coring for movements resulting in or associated with Huntington's. I think that is a take-home point. There are a lot of chat box questions, Dr. Suvirit, in regards to levosulfuride you mentioned, peripheral prokinetics like etopride, and whether they are also implicated in, or domperidone for that matter, in dyskinesias, your experience also.
So domperidone is classically safe because it's a peripheral dopamine receptor blocking drug. It doesn't cross the blood-brain barrier, so it's classically considered safe. Having said this, I have heard I have not I do not have any personal experience, but I have other neurologists or senior neurologists or movement disorder specialists mentioning that those who are taking very high dose of domperidone, like 60 milligram per day, they can develop mild. I think they developed oculogyric crisis or acute dystonia. I'm not very sure about the dyskinesia. Etopride, I have not seen any patient who is on etopride developing such kind of dyskinesia. Often patients are on some medication, such medications, and we uh, tend to attribute, but it's the levosulfuride that is more commonly associated with a lot of tardive syndromes. So it's our tendency to attribute all the tardive syndromes to the prides, etopride, prucalopride, but the evidence is not that much. Like there have been cases in literature, but it's difficult to correlate.
Okay.
So, how much is it possible that multiple types of dyskinesias or multiple origin dyskinesias in the same person? Suppose what Shobit was asking. So he has TD plus now someone has given levosulfuride and now dyskinesia is there. So in that, is it a very uncommon situation?
It in patients who have Parkinson's disease who are given levosulfuride, we see worsening of Parkinsonism more commonly than worsening of dyskinesia. Yes, they have levodopa-induced dyskinesia, but when they are on levosulfuride, they have worsening of the akinesia, worsening of the rigidity, worsening of the tremor. This is more commonly seen, and is when they develop dyskinesia, it's challenging to treat. For example, even if the patient is not prior to levosulfuride use, patient was not taking any anti-Parkinsonian medication, but after levosulfuride, when they develop dyskinesia as well as Parkinsonism, it's very challenging to treat, because when you try to treat dyskinesia with dopamine depleting drugs, the Parkinsonism worsens.
Yes. So wouldn't worsening of Parkinson's will mask dyskinesias if it is not a drug levodopa-induced dyskinesia? So
Yeah, so yeah, the if you give dopamine depleting agents to these patients, dyskinesia will be less. dyskinesia will be suppressed. But
Parkinson's
then the Parkinsonian, because you are blocking the dopamine receptors, you are reducing the hypersensitivity, the dyskinesia will be less. You are depleting the dopamine, and that's how you take care of the hypersensitivity, and that's how you reduce the dyskinesia, but the Parkinsonism will get worse. In those patients, if they tolerate, I often find that amantadine is useful.
But in context of what we treat in psychosis and bipolar disorders, amantadine can worsen the mood states, and
Yes.
it can decompensate a patient. Though we say that it works via NMDA receptor profile, but still. So then, how to go about it?
Yeah, but like in your patients, mostly they continue to be on some antipsychotic drugs, right? So we just talk to you guys, and we try to reduce the offending dose of the offending agent. We try to replace it by another drug, and we do try tetrabenazine in these patients, and we don't use amantadine like unless we see that we are not able to give tetrabenazine in a good dose in these patients. So just changing the drug. For example, patients who develop very bad tardive dyskinesia on risperidone, olanzapine, or haloperidol. Sometimes, like after talking to the psychiatrist, when we shift to aripiprazole, clozapine, and give some other drugs like GABAergic drugs, we are able to lessen the severity of the dyskinesia. We tell them that you cannot go completely off the antipsychotic agents because of your primary disorder, but we'll be able to reduce the dyskinesia. So amantadine in selected patients in which we are not able to achieve reduction in dyskinesia with optimization of other drugs, then we use. Otherwise, just change of the antipsychotic medication. And in those having bad dyskinesia, I don't hesitate to use botulinum toxin injections. Right? It reduces the severity of the lingual jaw spasms, and the patients often feel better.
And long-term outcomes of botulinum toxin for dyskinesias?
In patients who have compared to patients who have idiopathic oromandibular dystonia, the patients with tardive dyskinesia, over time we are able to reduce the dose of the botulinum toxin, and in some patients we know that about 30 to 40% will have resolution of symptoms in 3 to 4 years, resolution of tardive dyskinesia. In those patients, I have been able to completely go off. It's just when that in the starting phase, when the severity of dyskinesia is much, I use the botulinum toxin, but later I am able to reduce the dose and then omit further usage.
A very interesting question is that does handedness affect dyskinesias? Is it?
I think I have to search the literature
Never
a bit.
thought in that way. I think
Honestly, I have
never
not
thought in
read
that
such.
way.
And
Not read such.
sir, relatedly, that poor denture, because when we apply abnormal involuntary movement scale, it would cut 1 mark for the denture status.
Yes.
So how it can mimic or exacerbate dyskinesias?
Poor denture, poor oral
Very
hygiene.
pertinent point, because all dyskinesia and dystonia, they are both like, particularly dystonia, they do have some sensory triggers. So if poor denture, poor oral hygiene, these are like sensory triggers for abnormal movements, and they contribute to dyskinesia or dystonia. Like, but uh, we also see patients who are edentulous, and they will have such dyskinesia. Uh, Treatment of those conditions is important for as general health, but like I have not seen in my personal experience that treatment of this condition helps reduce the abnormal movements. You can do some palliative work, like if the patient has a lot of bruxism or patient has tongue bite, you put some teeth cap and there is some palliation of symptoms. If you put some teeth cap, there is prevention of the tongue bite, cheek bite, and the bruxism is not so severe, and the patient has some relief.
So, any distribution age-wise, childhood, geriatric, or general adult? What sort of dyskinesia is common there?
So younger people tend to develop in context of antipsychotic medication. In context of antipsychotic medications, younger people tend to develop dystonia more, and the elderly people tend to have classic tardive dyskinesia more often. So uh, and the
For
and
dyskinesia in general.
sorry,
For dyskinesias in general,
not related to antipsychotic medications.
not related to, yeah.
So dyskinesia, so as I mentioned, that dyskinesia in general means any type of abnormal involuntary movement. But when we speak about dyskinesia, we talk of chorea and chorea dystonia, but chorea predominantly. So chorea, yes, we see across all age groups, just the etiology is different. The most common cause of most common cause of chorea in elderly population with family history is Huntington's disease. But in children, it's more often it is acquired Sydenham's chorea, and then there are some genetic causes of chorea. In females or in middle age, the autoimmune causes take predominance, like antiphospholipid antibody syndrome or systemic lupus erythematosus.
There are two questions, Dr. Bhaumek, pertaining to hemifacial spasm. So can they be drug induced, or generally they are de novo?
We don't consider hemifacial spasm as drug induced. We generally consider this as form of some peripheral myoclonus or peripheral spasm induced by uh, abnormal activity of the facial nerve. It can be idiopathic, or many a times when you do some neuroimaging, there can be some neurovascular conflict between the facial nerve and the intracranial arteries.
Okay.
So
Supposedly, supposedly if a patient comes to us on haloperidol, develops dyskinesias, first acute and then tardive, and then we send the patient to you, you start him on tetrabenazine and patient responds. Dyskinesias, they subside. And we have already, maybe couple of months have gone by. Now, like, because it can play with your dysphoria and it can create postural drops and all. So what should be the plan? When shall we start tapering it up? Any guidelines or any broad approaches there?
No, but like if the patient is on haloperidol develops bothersome tardive dyskinesia, then only like if the tardive dyskinesia is not bothersome to the patient. For example, many patients of schizophrenia on antipsychotic medications will have some abnormal movements which we don't treat. But those who have bothersome tardive dyskinesia, those need to be treated. But we often advise the psychiatrists that if we can grade down from haloperidol, is it possible to change the drug from haloperidol to something else? So many of these patients are on combination of anticholinergic medication as well as haloperidol, and anticholinergic is known to, if there is no dystonia, just dyskinesia, anticholinergic agent now there is no question of acute dystonia, I reduce the anticholinergic medication or stop it, and I replace it by a dopamine depleting agent like tetrabenazine, and request the psychiatrist if it's possible to grade down from haloperidol. And after switching to a lower potency medication, second generation drug, or some agents which do not hang on to the dopamine receptor, D2 receptor for a longer time, like short acting agents. These agents, or clozapine, these agents may reduce the severity of dyskinesia, and then we can reduce the dose of tetrabenazine. So in my experience, like younger patients who are on antipsychotic medications for schizophrenia, they tolerate tetrabenazine well, like up to 75 milligram or even 100 milligram. But it's the elderly patients which I am worried about. They often develop Parkinsonism on such medication, and I have to reduce the dose of roughly like half tablet 3 times a day, like 12.5 milligrams 3 times a day.
Because anticholinergic, they say that after 4 months you try to taper it off. I think no specific duration is mentioned for drugs to manage tardive dyskinesias. Yes, sir. Alim, sir.
I think Dr. Zan had posted something on this line. TD movements are intermittent or they will persist all the time when the patient is awake.
Yeah, so there can be periods when tardive dyskinesia worsens. Like if the patient is sitting calmly, the tardive dyskinesia is not so much. But when the patient is actively thinking something, actively when trying to speak or do some movements at that time, during those times, tardive dyskinesia is more. Like these do not start appearing immediately after waking up, but as soon as the patient starts engaging in activities, the tardive dyskinesia comes into picture. Sometimes, like in front of people, when they are anxious, the tardive dyskinesia is more. So there are some triggers which make the abnormal movements more prominent, and when the patient is calm, the severity of the movements is less.
And regarding anticholinergic withdrawal, can you again specify immediate cessation or gradually taper off?
Anticholinergics for
Anticholinergic withdrawal in a patient now diagnosed as TD.
no, I taper it slowly. I have not, in my clinical practice, I have not suddenly stopped the anticholinergic medication.
Okay. And there are two questions regarding vitamin E. There is a huge hue and cry that this being an antioxidant, free radical scavenger, it will help in dyskinesias overall and in Korea. So, what role vitamin E has, Dr. Bhomik?
No scientific evidence I have not used. My anecdotal reports are there of vitamin E, pyridoxine. Then ginkgo biloba has some scientific evidence, so it is a second tier medication for tardive dyskinesia. I forgot to mention, but no vitamin E, vitamin or these things. I have no personal experience, and there is no scientific evidence as of now.
Okay, can escitalopram also cause tardive dyskinesia? Someone has also asked for benzodiazepines.
So, so tardive dyskinesia, if by definition should be labeled when a patient is on a drug which has a dopamine receptor blocking property. So these can be antipsychotic agents. These can be flunarizine, verapamil, metoclopramide, levosulpiride. So these are known to have some dopamine receptor blocking properties. So tardive dyskinesia, by definition, so many patients, as I mentioned, especially who are on long-term antidepressant drugs, which may include escitalopram, fluoxetine, fluoxamine, or tricyclic antidepressant medications, they develop some abnormal movements of the face. It's very difficult to prove that they are unless you have documented cases where you have stopped escitalopram and there is resolution of dyskinesia. It's very difficult to prove that this. Most often, you stop, you don't have a resolution of tardive dyskinesia, and classically dyskinesia. So in dopamine receptor blocking drugs related to tardive dyskinesia, you see that there is worsening of tardive dyskinesia on stopping these medications abruptly. And there is no such correlation with escitalopram in patients where there is a documented evidence that stopping escitalopram or replacing it by another drug has resulted in resolution or decrease in severity of tardive dyskinesia, then only we can believe. But I don't think it's proven in literature.
You're
Like,
saying
there are anecdotal reports, but it's very difficult to attribute generalize that this dyskinesia is caused by escitalopram. Like you may be able to tell us more because you use more.
No.
So I
No,
think
from my side.
sir, if patient is vulnerable, maybe so maybe an association. But I think as you said, causality very difficult to establish.
Mhm.
And also issue with TD is it's a chronic issue. The remission rates are very poor. So any drug will stop, it will not go off. So again,
Yes,
that is an issue.
very difficult to prove
A very
actually.
And I think amoxicillin is an antidepressant which has an antipsychotic properties. It is reported to be associated with a lot of
Yes.
extrapyramidal side effects, maybe TDs.
Yeah, so if drug actually is not available, then how will we diagnose TB? If she says some medication was taken, then we may not be able to diagnose TB, or we can still diagnose.
So, like a lot of times, like they don't come with all the previous records of medications, and in a very short consultation, we may miss out the medications, even if he has used dopamine receptor blocking drug for a very short time. These patients can also develop tardive dyskinesia, and this tardive dyskinesia tends to be persistent. There may be some genetic predisposition, we don't know, or some vulnerability, we don't know. So in the absence of, like if you have reviewed all the records thoroughly and if you don't find any dopamine receptor blocking drugs, then I think we should investigate for other causes, investigate. And if it is just limited to now, there are patients who have idiopathic. So we know that there is an entity known as idiopathic or spontaneous orofacial dyskinesia. So many patients who have not been on any drug throughout the life, they can develop dyskinesia. They can develop oromandibular dystonia. Okay, they can develop adult onset tic disorder limited to the cranial musculature, which looks like dystonia. So there are patients like that. So in those patients should not be labeled as tardive dyskinesia.
So in that case, whether neuroimaging normal, maybe an MRI will rule out the other
Yeah,
possibility.
if it's just just remains restricted to one region and you follow them up and there is no additional involvement. There may be some contagious in neck involvement, eye involvement, some up and down progression may be there, but it doesn't generalize and additional neurological features do not develop, then we call it idiopathic, because idiopathic dystonia is common in middle age to elderly age group. And neuroimaging can give clue to some disorders. In my experience, like a lot of patients with uh, are there who have very typical head dyskinesia after usage of low dose of levosulfuride or certain other dopamine receptor blocking drugs. They have in neuroimaging they have a lot of vascular changes, so they are prone to develop such dyskinesias. And additionally, their gait is also affected. They are Parkinsonian. Their cognition is also affected. In those patients, treatment of such dyskinesia with tetrabenazine becomes very difficult and challenging.
I think one more question, Dr. Bhomik. We say that GABAergic hypothesis of TD. So we say that a high dose of benzodiazepine like clonazepam has few reports having therapeutic benefit in TD. One of the good questions here is valproate. Well, whether valproate is an implicated in TD or therapeutically implicated in TD.
Is therapeutic. It induces a Parkinsonian state. Like if patients who are on chronic valproate therapy for epilepsy, they often develop tremor and mild form of Parkinsonism. So valproate is actually a therapeutic. Like in when tetrabenazine was not available in patients of syndrome chorea, valproate was used. So it has an anti-dyskinetic property.
Okay.
So
In acute dystonia, I think we're not covering today. Promethazine and acute dystonia, someone has asked. How are we?
तुम लोग और बुलाने का मन नहीं है लगता है, सारा एक दिन में सीख जाओगे तुम लोग.
Anyway, just summarizing acute dystonia, we have to stop the culprit medication, and if the patient is having, you cannot stop the medication because of patient's psychiatric issues. We have to, for example, a patient on schizophrenia, patient of schizophrenia who was getting a very high dose of risperidone, developed cervical dystonia, but the psychiatrist referred to us, even using anticholinergic medication did not lead to resolution of dystonia. We had to give botulinum toxin injections that led to partial resolution, and gradually the patient after 6 months has started to improve a lot. And the psychiatrist just changed the medication. Actually, the patient is now on a very low dose of clozapine. So patient has been informed that you may have a risk of relapse of symptoms of schizophrenia, but because the cervical dystonia was so bad after starting risperidone and it developed acutely, the psychiatrist decided to change the medication and treat with anticholinergic agents and botulinum toxin injections.
But once you have replaced risperidone with clozapine, I think relapse chances are very less if you can manage if adequate doses are good, because that's more potent than risperidone. So I think that's a great choice.
That's a great choice. Okay.
there is a question.
So,
Yes, sir.
any pointers, indicators of which persons are predisposed to have dystonia or movement disorder? Suppose we want to be more alert, in which sort of person should
Risk
we be
factors.
more alert?
Younger
Risk
people,
factors.
Number one is younger age.
younger people. So I don't know about any other predisposition.
And dystonia, I'll tell younger age, and the other is if you, in our practice, you are using
No,
antipsychotics.
dystonia, I'm talking about dyskinesia in general. Dyskinesias.
So dyskinesia, I think any patient, more commonly it's seen in
So
more
let me rephrase.
people come to me with
Any
sorry?
phenotype any phenotype which is going to develop dyskinesia later on.
Yeah, so this is not being studied characteristically, but patients, categorically, there are some trends we can see from the studies or from our personal experience. So patients who have a lot of functional symptoms, like the symptoms which are not clearly attributable to any organic disease, they keep on complaining of some epigastric pain, reflux, and these sort of patients, they will also have some migraine, some painful syndromes. These patients, in my experience, tend to develop adverse reaction to this dopamine receptor blocking drugs. So even after stopping the medication, for example, if they even if they develop these abnormal movements which are very bothersome to the patient or it's bothersome to the relatives, they don't want to be off levosulpiride. Means if you just stop levosulpiride, they will demand it. So I don't know whether these patients are at risk of developing these kind of they have a dysfunctional brain and are predisposed to develop side effects of these medications. So function.
Any
Yes.
any Ayurvedic medications that any alternative medicines that will cause dyskinesias and dystonias and TDs?
Tardive dyskinesia, Ayurvedic, I don't know.
Yeah, so what Dr. Ali Mans, I recently had a patient, elderly with depression, anxiety, and No, I think for her constipation, she was taking some Ayurvedic preparation. We never bothered to ask her. Doing very well with escitalopram and then suddenly developed Parkinsonian symptoms, but not typical. So a lot of dyskinetic movements. And we're thinking that maybe this is an onset of a neurodegenerative disease, got MRI done and everything. And then over the course of a long history taking, we realized that this was more of heavy metal. So she was using the Ayurvedic preparation with heavy metals in it. And the neurologist in the hospital then got the assessment done. I think we found heavy metals. And though she's off the Ayurvedic preparations, her dyskinetic movements have not completely gone away. So do you think, Dr. Bombing, that when they develop these dyskinetic movements because of, say, heavy metal toxicity, because of Ayurvedic preparations, do those movements go away?
Yeah, so as I have not seen myself, but there are literature reports and some cases from Nimhans where usage of some Ayurvedic medication containing mercury led to some abnormal neurological syndrome, including sleep disorder. And once it was found and it was omitted clearly, the patients started improving. So heavy metal intoxication, important thing is that if you are able to detect early uh, and before any permanent degeneration sets in, if you are able to take away the medications, then there can be chances of improvement. But sometimes they lead to, like, a lot of heavy metals lead to permanent neurodegeneration, right? They damage the basal ganglia, cerebellum, and those patients they may have. You may prevent further progression, but whatever deficits develop are there.
Because interestingly
Not
enough,
classic dyskinesia. I'm not able to think about one form of dyskinesia attributable to one particular heavy metal. No, no.
because in Dehradun, a lot of people from Hardwar, they will take a lot of Ayurvedic formulations. We just reported Geloy leading to lingual dystonias. It was published in PCC. So again,
Yeah.
an interesting thing.
Oh, this dyskinesia is lot. And then there are some people from Middle East who have a habit of chewing something. I forgot the name of the item. They have the habit of chewing that thing, and it's also reported from Jaslok. Then they will develop this oromandibular dyskinesia or orolingual dyskinesia by this chewing habit, continuous chewing habit.
I think in clinical.
So last question, last question from my side. So Rohit, have you or any of your colleagues developed any AI algorithm so that I upload the video and it's using the diagnosis of what sort of movement is there, movement disorder? Are you working on that?
Yeah, not me specifically, but those who are into this. I know some of my colleagues in AIMS who are interested in artificial intelligence and machine learning. And now we have to teach the machine what kind of movements are there. So yes, so machine learning is very good tool to detect Parkinsonian disorders. It can be a very good tool to diagnose the other movement disorders like chorea, dystonia. So yes, we can, but we have to teach them.
I think Alim sir, coming to last two questions. 65-year-old female with perioral movements on MRI. They have lacunar infarcts, basal ganglia, cornea redata, centrum semiovale with suboptimal white matter tracts bilaterally. They're not responding to tetrabenazine. What should be the further approach?
I like tetrabenazine, what dose? Like that's important to ask. If the patient is tolerating, we can add, and is not developing side effects, we can increase the dose of tetrabenazine.
Maximum to how much?
I have rarely gone beyond 125 milligram. Rarely, 125 milligram is the max that I have in my patients. Above that, it's very difficult in elderly patients. But literature says can go up to 400 milligram. I am not sure if.
So suppose a patient is not able to go beyond 100, so tetrabenazine will block at 100. So any additional
Yeah,
steps
so
that we can do now?
the tetrabenazine is not working. I'll think of the second tier agents. So second tier agents will include amantadine and the GABAergic drugs like clonazepam and zolpidem and clozapine clozapine can sometimes be very helpful in these patients. And if this is not working, I can and these movements are very bothersome to the patient, then I can use some low dose of dopamine receptor blocking drugs to reduce the severity of dyskinesia. If there is a dystonic component to these movements and the movements are bothersome, then botulinum toxin injections can also be helpful.
So last question from my side, that twice it has reflected in the chat box. Tics, you mentioned in last two presentations, tics versus dyskinesias. Dr. Bhaumek, very vividly, if you can briefly.
So yeah, so tics we classically do not include in the dyskinesias. It's a separate disorder. So tics are jerky movements and are like if it involves one type of movement, it's called stereotypic, or it's a repetitive. The same type of movement occurs again and again, but sometimes it can involve different body parts or different muscle groups, and at that time you can get multifocal or generalized tics. The important feature about tics is that there is a sensory component to it. Many patients, especially middle-aged or old-age people, will complain about an urge to do the movements and discomfort if they suppress the movement, and other feature will be suppressibility. The patients will be, they can suppress chorea, dyskinesia up to an extent, but the suppressibility is for tics is on a greater extent. Tics are jerky, right? Dyskinesia, oral lingual dyskinesia are continuous movements. These are and many times they are like stereotypical, same type of movement occurring again and again. Tics, jerky, one movement gone, moment gone.
Thank you, Surit, for patiently listening to us answering our queries. So back to chairpersons for the remarks. Then we go to the answer.
I mean, I couldn't include a lot of videos. There are several videos, and when we come across dyskinesia or chorea dystonia, or combination of chorea dyskinesia and stereotypy with behavioral issues, psychiatric issues, then there are several disorders which can have both the symptoms. So it may not be a primary psychiatric disorder. It may be a genetic disorder. For example, patients of neuroacanthocytosis often have a lot of psychiatric issues. Macular disease often have a lot of behavioral issues, and then they develop this classical orolingual dyskinesia and tongue protrusion dystonia. So it's very important to catch those patients. And then patients of Huntington disease, in addition to chorea, they can have a lot of behavioral psychiatric issues. They can have apathy, they can have depression. It is important to catch those diseases. So the clues can be there from examination. Like in addition to the movement abnormalities, you will get some other forms of neurological abnormalities, or you can get some clues from the systemic features, or you can get some clues from the neuroimaging. So these will help in catching these disorders. And vis-a-vis, more commonly, there will be patients of primary psychiatric disorder coming with dopamine receptor blocking drugs and having some movements related to either usage of those drugs or because of the patient's condition.
Okay. Thank you. So to chairpersons now. Any comments, closing comments?
Thank you so much again, Dr. Bhaumek. As psychiatrists and neurologists, we are always hand in glove working together in the same field, that is the brain. So, because like I told you right in the beginning, the interplay of the symptoms. So a huge learning for all the psychiatrists, I think, who are in the meeting today. to identify the different kind of dyskinesias, and it was such a lucid presentation. So thank you so much. And now we know whom to reach out to. If we have a query, we'll just send you the video, and I'm sure that you will help us before your AI tool comes into play. So thank you so much for a very, very enlightening session. And I think you had sessions even earlier. We're looking forward to more collaboration with you. Over to Dr. Topanpati, sir.
If Anveshak is there, he can chip in. Otherwise, we go to Tufan, sir. Anveshak,
Yes,
yeah,
sir.
please.
And nothing more to say. Just thanks from my side for such an insightful deliberation. Cleared a lot of my doubts, and I guess everybody's doubt has been cleared. And it was. I also congratulate the Thursday Musing team, Alim sir, Sobit sir, Vishal sir, and Amrit sir for putting up this topic, because this has been always a gray area for us as a psychiatrist to differentiate various movement disorders. So thank you, Thursday Musing team, and also Dr. Bhumik sir for such an excellent deliberation. And looking forward for more such insightful lectures in Thursday Musing. Thank you.
Thank you, Anveshak. Tufan, sir, over to you.
I'm having fever and cough, so that is why I was remaining off screen and silent. But excellent topic by Dr. Bhumik. And in continuation from the robust presentation, we feel enlightened. To the best of my knowledge, AI status in tardive dyskinesia is only support. You can only assist in diagnosis, suggest therapies, and they have also admitted some flaws for many medical disorders. A few days ago, I asked ChatGPT-4 about all these questions. That was their reply, not my reply. So it is limited, but dreams are that it will be there. With this, I thank everybody and hand over to Amrit.
Thank you, Dr. Souvik. It was great. We now understand where Shobit is understanding so many things and he's able to tell a lot of things. He has got a good set of friends. That's great. And the videos were nice. The way you explained, it was that you made it very simple actually. If a person like Alim can understand, I mean, then you have achieved what you wanted to achieve. क्योंकि उसको डिस्टोनिया और डिस्कैनेसिया में बस उसको पूछा गया था एक बार एग्जाम में, बोला स्पेलिंग में डिफरेंस है सर. सो नाउ दैट ही हैज अंडरस्टूड, आई थिंक यू हैव डन अ ग्रेट जॉब and we'll be calling you. You told there are a lot of videos left. We'll be, more than happy to have you again. Shobit, if possible, we'll call him again. A lot of PGs learn, and for us consultants who have not learned, we are learning newer things. And for some people who have learned the wrong things, they will unlearn and learn again. So whole in all, it was wonderful. We had a lot of people, core, neuropsychiatric things were there. So we have more than 180, 190 people. And that's wonderful. Thank you again. I would like to thank Dr. Tufan sir, my great friend Alim, Sobit, and Vishal, and the chairpersons, Madam and Anveshak. You've been wonderful. Thank you for attending our Thursday musings. Catch you again next week. Good night.
Thank you.
Sobit, कुछ तो शोभित मेरे को बोला था मेरे दोस्त को अच्छे से प्रेस करना. मतलब ठीक है, पैसे लूंगा.
Thanks.
Good night.
I do learn a lot.
Thank you,
from
Surat.
this.
Surat.
Um,
Yeah, yeah, yeah. Thank you. Thank you, Surat. Surat.
Thank you so much.
Very, very nice presentation. Very enthusiastic and practical also. Thank you so much.
Great. Thank you so much. Thank you.
Thank you, sir.
Thank you. Ending the meeting with permission.